good morning or good afternoon or good evening or good night, wherever you are around the world and participating in this meeting. I'm really thankful to the organizers that they have invited me to chair one of the sessions in this worldwide event dedicated to the critically ill lung. We are now in a rather challenging time from the personal perspective, but also from the professional one. We witness a huge progress in digitization, and one of the evidences is this streaming event and this conference. And when I thought about this session, I had the idea that I will try to smuggle in a few analog inputs into the digital world. For instance, like this purely mechanical announcement of this session. So the title of the session is Acute Respiratory Distress Syndrome. And you are probably wondering why it is called ARDS, because ARDS has been the most frequently used. You have been hearing all the time. But that's how it is, and we will cover different topics in this session. We will have 3 different speakers. But before I come to the speakers, let me briefly introduce myself. My name is Ines Frerichs, and I'm affiliated with the Christian Albrecht University in Kiel, which is in the very north of Germany. And specifically, I'm in the Department of Anesthesiology and Intensive Care Medicine. The colleagues that will talk today are really highly esteemed scientists and clinicians, and they will cover topics like mechanical ventilation and specifically the patient-ventilator interaction, new monitoring methods, electrical impedance tomography, and finally also some therapeutic approaches like prone positioning. The colleagues that will give you the talks are those that I have been meeting for many, many years at different places, of course, in conference venues, but also in animal experimental labs, but even in such crazy places at football stadiums. And therefore, I'm really, and I think you see it, I'm happy about the people who will talk today. So the first speaker will be Louis Blanc, and I'm sure that he will show a lot of waveforms in his presentation, probably a little bit more complex ones than my simple drawing here, because he will talk about the patient, ventilator, and synchronous. So Louis, it's your talk now, please.
So I will, my talk is about asynchronous in mechanical ventilation, but I will talk a little bit about asynchronous in patients with COVID ARDS, because this is a new feature. First, my conflict of interest. I'm an inventor of 2 patents to monitor signals from the medical devices, and also founder of Better Care, which is a spin-off of my institution. This is the classical diagram of Tobin, and I like it very much because this can often be seen in critical care. I mean, this is a patient that is not interacting well with the ventilator, and when that happens, this patient experiments diaphoresis, nasal flaring, cyanosis, tachypnea, using all the muscles to expirate and inspirate, tachycardic, and so on. When that happens, this is not an ideal situation because this patient presents dyspnea, hunger, discomfort, delirium, anxiety, and all these may induce lung injury, muscle injury, and perhaps increase mortality. Okay, when we classify asynchronous, there are many ways, but I like this classification that we use. It's present in a couple of reviews, mostly appearing simultaneously, which is the high drive, when patients have the high drive, when it's insufficient assistance. Maybe this is the case in the COVID patients, and I will speak later. Or maybe when the low respiratory drive, which is, in that case, over assistance. This might be the case of ineffective effort, but I will mostly concentrate on that. I mean, when we look at that, when inspiratory flow is not sufficient, So the patient has air hunger, needs more air. And this is the classic asynchrony that if we increase flow and we adjust inspiratory time, this can be solved. But when that happens, look at this breath. If this patient has discomfort, all the work of breathing is done by the patient and not, in that case, by the ventilator. So we need to, pay attention to the flow needs of the patient. Look at here, again, flow, airway pressure, and tidal volume, and this patient, airflow is clearly insufficient. This appears as a CPAP tracing rather than a pressure airway tracing in a patient ventilated with a volume control, a square flow. So flow is here, below 40, because the usual flow, to avoid that asynchrony, is around 60 liters per minute. So we need to adjust, both inspiratory time of the patient to inspiratory time of the ventilator, and also to adjust the flow for the patient flow demand. Having said that, again, this causes dyspnea, air hunger, and we need to pay attention. It's not the topic of that talk, because all these projects to the limbic system and can cause cognitive, perhaps, alterations in the patients. Again, this is a study of my group. We did that several years ago, trying to characterize asynchronies, and asynchronies are always present. As you will see here, asynchronies happen right away after intubation until the end, and all the patients have asynchronies. And when we try to characterize if there is any pattern or whether we can predict it, it's not possible. This patient has moderate asynchronies during 5 days, and then in that day, a huge amount of asynchronies, almost no asynchronies at the beginning throughout the mechanical ventilation period. So we need to pay attention always. And nowadays, unless you have dedicated software, this needs to be done at the bedside. We were worried about whether asynchronies are associated with outcome. Since in our first investigation, although the paper was not designed to answer that question, maybe it seemed that there was some increase in mortality. Then we did this analysis in almost 140 patients, as you will see here, and we use a complex, mathematical models using Bayesian models. And we, look at that SOFA, during daily SOFA and asynchronous. And SOFA perfectly discriminates the patient that will be alive, that the patients that will die in the ICU, but not asynchronous. Asynchronous per se, it seems that they are maybe associated with survival. So maybe we need to talk of permissive asynchronies, and maybe there are some asynchronies that really can cause injury, whether other type of asynchronies are associated by the fact that the patients are breathing, within a ventilator. The group of Vaporidi and Georgopoulos presented this nice investigation. They show that it's not asynchronies, it's how asynchronies happen. They define clusters as a 3-minute period with more than 30 ineffective efforts. And as you will see here, characterizing this was associated with mortality. And in this data here shows that the power, which is the number of asynchronies, in a certain, in a predefined duration, when there is high power, high duration, high intensity, then, this is associated with mortality. This was one day, and only looking one of asynchrony, perhaps caused by over-assistance, which is ineffective efforts. This is an example of one of our patients. This is not COVID yet. This is, we can call that breath stacking. You will see double cycling with breath stacking. And this patient is presented regularly, all these episodes. And we must pay attention, because each time that happens, if there is 2 inspirations without expiration, there is an increase in airway pressure, tidal volume is double. So ventilation is no more protective, and this can happen in clusters. This is a clusters not of ineffective efforts, of double efforts, where, there is certain power and certain durations. Up to now, we are classifying this like that. So this is a paper that now is under review. It's because we want to answer the question whether in any patient on mechanical ventilation, clusters of double cycling and ineffective efforts can be associated with mortality. So we look at 180 patients. The proportion, the number of missing records, is quite acceptable. So we get more than 70-75% of time in mechanical ventilation where we get the signals. 45,000 hours and almost 60 million breaths. And this is an example, again, of a cluster. So the patients breathe. The patients breathe here. I mean, and they present asynchronous. But in this period here of 45 minutes, I mean, it is a cluster where, I mean, breath stacking and double cycling is repeatedly happen during that period. When we examine whether clusters were present, so clusters per day were present, I mean, in all patients during all time of mechanical ventilation. When we separate mechanical ventilation as the first 48 hours and the rest, we found that there is less clusters in the first 48 hours. And maybe this has, I mean, makes sense because the patients are more paralyzed, perhaps more sedated, and so on. However, when we examine power and duration in the terms I explained before, I mean, you will see how there is no, you will see here difference in that case in power and duration. The results of that study, all patients had clusters. However, when we using mathematical models, I mean, we found that clusters were positively associated with survival. So the patients who survive present asynchronous, and sometimes those asynchronous are associated in clusters. However, the clusters that present high power and high duration are negatively associated with survival, not only in total, but also in the first period of mechanical ventilation, as you will see here, where the number of clusters is less. So here, the hypothesis is that asynchronous and clusters maybe happen in all patients, but how them happen is important. This is just an accepted paper to publish that we did with a group of Brochard, just to set up an algorithm for automatic diagnosis of reverse triggering. All of you know that reverse triggering is an asynchrony that happens when, I mean, a ventilator breath triggers an inspiratory effort of the patient. If this causes breath stacking because the effort is so high, you will see an example here, or maybe in that case, the effort, I mean, triggered by the ventilator breath, in that cases, I mean, the decrease in the muscular pressure is less because the inspiratory effort also is less. When we analyze it in the terms of the muscular pressure in those patients that presented reverse triggering without breath stacking, or the patients presenting reverse triggering with breath stacking, let's say less effort or more effort, you see that the muscular pressure is quite higher. So in that group, reverse triggering with breath stacking perhaps is the group that can cause injury. This is the control group because it's pressure support ventilation, it is synchronous, and in that group, reverse trigger by definition cannot occur because all the breaths are, I mean, triggered by the patient. So let's now move to the COVID. I mean, all of us know COVID. COVID is characterized by hypoxemia because the virus has some cytopathic to the alveolar cells, then cause death of patient, and is characterized by an increase in respiratory drive in many patients. After that, increase in rate, increase in effort, and dyspnea. And this is a patient, a COVID patient. But I would like you to look at this. This is volume control ventilation, decelerated flow, but here the flow may be sufficient. It's okay, almost 60 liters per minute. But this patient triggers the ventilator, but has a profound swing of inspiratory pressure that goes throughout all the breath, and the breath is patient trigger. I mean, this is something that is barely seen in the intensive care units. So the problem here is if that happened only in several breaths, or may this happen all the time during mechanical ventilation. Is this important? Yes, because Snow and co-workers look at that PO1 and the occlusion muscular pressure after an expiratory occlusion, and they found that the patients with high PO1 and more, I mean, negative pressure, let's say more swing in the muscular pressure, were the patients where there was a relapse, so they need to be reconnected to the mechanical ventilation, and then the prognostic probably, I mean, in that case was worse. Then I look at the PubMed and COVID. Now, this is October 24. I found using COVID-19 coronavirus or SARS-CoV-2 more than 80,000 results. When I add asynchronous or patient ventilator interactions, 53, when I add asynchronous, only 8. And these are two examples. The only two papers that show something on asynchronous during the COVID-19 RADS pandemic. And this is just a case report, 9 patients. And authors describe this patient has a huge respiratory drive that really causes air hunger. And they say also when that happens, we must paralyze the patient. Similarly here, this group of China use a deep learning algorithm for detecting, in that case, patient ventilator interactions. This is the survivors in green, the non-survivors in red. This is just an observational study. All patients present an asynchronous and no clear association in that case with mortality. But the important thing is that it seems that everybody presented asynchronous, and they state, again, when that happens, and if this is, important, they use mild relaxants. Look at this other example here. This, again, the flow is 60 liters per minute, decelerated, again, or 58. But now, the patient is not triggering anything. It's a time-cycled ventilator breath that here, in the middle of inspiration, there is a swing of the inspiratory effort of the patient. So this is a reverse triggering and a reverse triggering, but not this one. This is patient. In that case, this is simply a short cycling. Is patient triggered? In that case, that again, the patient triggers the ventilator, but the flow isn't off. So what happened here? Maybe there are other mechanisms not related with the flow, maybe not related with the metabolism, maybe really related with the brain in this particular pathology that we need to investigate more. So here another example. Again, this is in volume control, a square flow, not decelerating flow. Again, the flow here is 45 and maybe 2 mechanisms account, but the fact is this is a reverse triggering again that elicits a huge swing, as you will see here, of negative pressure that, this is PEEP14, this goes to 2 centimeters water. In terms of transpulmonary pressure, this is huge. So this is probably a very injurious mechanism because this strong effort causes large transpulmonary pressure, pendulum deformation, and maybe injury induced by the patient. When we look at clusters using the software we have, we here define clusters never seen before. Here is from 2 to 12. It's 10 hours. This patient presents 3 clusters, 2 representative patients. The power is more than 3,000. The duration, more than 4 hours. Almost 4,000 the power, which means that there are 4,000 events in this duration and in this duration. And that one is a cluster that lasts 12 hours with more than 14,000 of power and almost 12 hours. These are COVID patients. Whether that happened, we need really to pay attention because in my experience dealing with waveforms, and so I have never seen this before. So just to conclude, in the LungSafe study, it tells us in a huge cohort of RADS before COVID area that, paralysis or mild relaxants was used in 37.8% of the patients. But in the COVID series, Ferrando in Spain, 79, the French paper that now is in intensive care medicine, 88 in almost 5,000 patients. In my institution, more 80%. In New York, Cummings, only 27. This is one example. This is just one, but Cursell in all these patients, 84. Maybe indirectly, the clinicians, are protecting the patients towards, this high drive by paralyzing them, because if not, this huge amount of, clusters of desynchronies possibly causing injury may happen. So if we see that a bedside clinician use that, to have better patient ventilator interaction and protect. This is a theory. We need clearly to investigate more. And just to finish, this is a picture of our 5th ICU during the first wave of the pandemic. I show this you here because we built that in 7-8 days, and I would like to thank professionals, nurses, all the people that were here because their work was extraordinary. So my really, really recognition, to all of them. Thank you very much.
So yes, and I will talk about the use of electron beam tomography and trying to answer the question, why is it important? My disclosures, probably the only ones related to the topic of this presentation, are that I've received research support and grants from Timpel, which is a company devoted to the development of EIT technology. So let us try to answer this question. So why is EIT important? Well, EIT is, as you know, is a functional imaging monitoring technology that, due to its unique characteristics, has become a powerful monitoring tool at the bedside. And what I especially like about my presentation today is that usually, and Ines is a good example of this, she has done a lot of research. When we talk about EIT, we talk about all the potential it has and all the fine research we can do with this. So I would like to tell you now that it is a reality. So it's available at the bedside, and most of the data I'm presenting are actually recorded in routine clinical practice. And I think this is a major step forward in this technology because it's available and it's very useful. And I'll try to convince you about this. So one of the most celebrated applications of EIT nowadays is its use for individualizing the level of PEEP in complex to ventilate patients such as the ARDS and COVID. And I will also talk a lot about COVID patients in this presentation because that's what we have been suffering the last months, all of us. So this nice publication of Costa and co-workers looked at the possibility of using electron beam tomography to titrate the level of PEEP, combining the concept of EIT with another well-established concept, which is long recruitment and decremental PEEP titration. And they were able to demonstrate that EIT can detect with quite a nice level of precision the amount of hyperdistension and lung collapse during a decremental PEEP trial, which are the two mechanisms most directly involved with ventilation-induced lung injury. So in this paper, a few cases were presented, and this is one of them. So you see here the evolution during the decremental PEEP trial from high levels of PEEP 23 down to 7. And the algorithm developed by Costa and co-workers was able to identify at high levels of PEEP those pixels in which low compliance was due to hyperdistension. And they marked these pixels in white. And as the PEEP titration proceeded to lower levels of PEEP, they were also able to identify at low levels of PEEP those pixels where the low compliance was due to lung collapse or predominantly due to lung collapse. And they marked these pixels in blue. So when looking at a more detailed evolution of this PEEP titration, you see here the PEEP levels from higher to lower levels, the compliance in green, and you remember that the maximum compliance in this context, which is really gives us a lot of information about the mechanical behavior of the lung during this decremental PEEP titration. The point of maximum compliance is probably marking this transition from an open lung to a collapsed lung, where collapse starts to increase. But with EIT, we can actually zoom into this mechanical behavior and look, for example, at the amount of overdistension or hyperdistension in EIT terms, where you see that as expected at high levels of PEEP, you have a high level or greater amount of the lung that is submitted to overdistension. And as PEEP levels are decreased, this hyperdistension decreases almost to negligible levels. So in this preliminary study also, there was an evaluation and comparison with the gold standard, which is CT. And actually, CT behaved here in the case of overinflated lung regions in a similar way with a good correspondence with EIT. And the same happened here with collapse. In red, you see here the amount of collapse is increasing in this patient quite rapidly, even at high levels of PEEP. And it also matched very well with the amount of non-aerated tissue, that is collapsed tissue in the CT scan, which this nice correspondence has been validated and corroborated in further experimental validations and clinical studies. So a nice message about this curve is that it gives a lot of information, and probably this crossing point, so where the lines of overdistension and collapse cross, is actually indicating us in terms of lung protection, which might be the best level of PEEP for this particular patient, because this point actually reflects the best compromise between the minimum amount of overdistension and the minimum amount of lung collapse. So this is how one of the current available monitors look like in clinical practice. And this is a PEEP titration here. What the system then provides is this type of graph where we can see the mechanical behavior of the lung. we get some information regarding mechanics, and you see here at the point of the crossing point and the PEEP level. And then you can also have an historical view of the different PEEP steps with marking the pixels of the parts of the lung that are submitted to overdistension at high levels of PEEP and collapse at low levels of PEEP, which gives you a direct visual information about this. And here, again, at the crossing point, you have the best compromise between minimum overdistension and minimum collapse. And it's also indicating you where in the lung are the problems happening, which I think is also an important clinical information that you could take away with such kind of analysis. So let me put you a few examples on how we have been using this tool, which we have been using a lot in this COVID pandemic in COVID patients. So this is a graph of a PEEP titration of a COVID patient. And you see here the levels of PEEP, 16 centimeters of water down to 4. You see the compliance again in green, and I have the same colors here. And you see the huge amount of overdistension. And you see also that the crossing point between maximum overdistension and collapse is occurring at low levels of PEEP. This has been quite a constant behavior, especially at the beginning or the early phases of these COVID patients. Usually not so much collapse, as shown here, with the little amounts of collapse, even at low levels of PEEP, not so much dependent on high levels of PEEP. And more importantly, telling us that the real problem of mechanical ventilation of these patients was overdistension. And you see here that with fairly regular, normally levels of PEEP, the lungs were submitted to quite a significant amount of overdistension. So in one graph, we get a full view of the behavior of a very constant behavior of the COVID patients we have been treating. So this patient was then turned into the prone position, which has been one of the most frequently used adjuvant therapies. So in prone positioning, we did exactly the same. So we performed exactly the same recruitment maneuver, and we performed exactly the same PEEP titration process. And you see here the difference. So the compliance curve is shifted upwards, so the lung increased in compliance, so it improved in the mechanical behavior. So the crossing point did not change that much, but look, the interesting information here is that prone positioning for every single PEEP level, the amount of overdistension was much less, meaning that this intervention was quite actually a good one, allowing us to improve the lung protective setting in this patient. So let me put you another example. This is another COVID patient. Again, the same procedure. PEEP titration from high to low levels. We have the curves here. We have the crossing point. Now at a little higher level of PEEP. And now the patient was turned prone again. And you see in this case, something different happens. So here the crossing point is almost at the same level. The compliance curve is totally different, indicating more overdistension and a high level of compliance at the very end at low levels of PEEP. But now what happens is that for each PEEP level, this patient was submitted to a higher overdistension. So in this particular case, and this information given by EIT, prone positioning was probably not a good idea because it did not improve the protective conditions of the lung, independently of whether it caused or not an improvement in oxygenation. So here you have this behavior in the supine in the prone position, now looking at the functional images of hyperdistension and collapse. And you see here clearly that for each PEEP step, the amount of overdistension was much larger in the prone position as compared to the supine position. Even the amount of collapse now occurring in the ventral part of the lung, which is now the dependent portion, was larger than in the supine position. So again, a very important clinical information that in this particular patient, in this moment of its evolution, prone position might not have been a good idea. And also important is to see that how critical it is to fine-tune your PEEP level in these patients, because you can move from an optimal condition to quite an overdistension condition very easily. Only just one PEEP step here from 10, which is the crossing point, to 12. You see that the amount of overdistension increases significantly both in supine and prone position. And if you move 2 centimeters of water or decremental PEEP steps, so 4 centimeters of water of PEEP, this gets even worse. And I have to remind you that 14 centimeters of water of PEEP is not so unusual in patients with ARDS. So, but it might have been a problem in some COVID patients because of the higher risk of overdistension. Another way of looking at the responses to PEEP using EIT is using one of the well-described indexes that talk about the distribution, the homogeneity of the distribution of ventilation. This is the center of ventilation, and it's a very simple and useful parameter where the scale goes from 0 to 100 from the ventral to the dorsal part of the lung. And ideally, we would like to set our ventilator settings so that the ventilation would be centered in the middle of the lung. So we have equal distribution in the upper and the lower part of the lung. So this number will be close to 50. So you see here, there's a nice recent publication, also in a COVID patient. You see here that the patient was quite sick with poor oxygenation. The PEEP level was 9. The compliance was not that low, as usual in the early stages of COVID. And you see that because of the poor oxygenation, the clinicians decided to increase the level of PEEP. And you see here that this increase was actually a good action because the center of ventilation moved more towards the center. The oxygenation improved. The PEEP was higher, but the compliance was also increased a lot, so that the plateau pressure and driving pressure did not increase that much. So it was a good intervention to improve the patient condition and continuously providing lung protective ventilation. But then only 24 hours later, the same settings, the same level of PEEP, EIT offered a different picture. So now the center of ventilation moved down, so meaning that ventilation now was shifted more to the lower part of the lung. And you see that this was associated with a decrease in compliance. And I think this is a very important message of this publication, is that oxygenation changed. It even improved a little bit, but this was not actually a good thing for the lung because it was less protected with more of this tension, increasing in driving pressure and a decrease in compliance. So then when looking at this picture, the clinicians interpreted, I think correctly, that probably now as the lung had probably improved over this period of 24 hours, this PEEP was excessive to this patient. So what they did now is they reduced the level of PEEP to 10. And again, no significant changes in oxygenation, but again, back to a normal compliance. And I think this is a very important aspect of such technologies that allow us to monitor what's happening at the bedside. Because one of the problems that we have in the clinic is to de-escalate the things we do. And of course, the patient was doing all right with 16 of PEEP. And if we don't have this additional information, if we only look at the blood gases, we would have continued to apply this level of PEEP, probably promoting more overdistension, unnecessarily high PEEP. And these monitoring options allows us to make better clinical decisions by looking at how the lung is behaving. So also, it is becoming a reality that we can measure perfusion at the bedside using the saline bonus injection technique that allows us to have information regarding the regional distribution of pulmonary blood flow. And this, of course, now is giving us a much more broader picture of what's happening. And I remind you that, especially in COVID patients, it was really sometimes really tough and complicated to interpret the gas exchange abnormalities in these patients. So this nice paper looked at the effects, or trying to understand the effects of prone from this perspective. And this is a cohort of 9 patients only. And you see here, as expected, when the patient was turned prone, they had an increase in ventilation in the dorsal regions with not so much change in perfusion. This is something we know. But then when they matched this ventilation to the perfusion, they realized, well, that proning in these patients overall caused an improvement in VQ matching. So they were able to reduce the amount of dead space or high VQ areas in the ventral regions and reduce the amount of shunt in the dorsal regions. So that these patients were responding in a good way to the prone position, at least in terms of VQ distribution. When zooming into the behavior of these patients, now they looked at what happened when they increased the level of PEEP, and then they created, and this is a very nice, maybe in the future available tool, of VQ maps, where the pixels of the image having a behavior of a high VQ relationship or dead space are depicted in blue, and the shunt areas or low VQ areas are depicted in red. And you see here the changes when these patients were submitted to an increase in PEEP of 6 centimeters of water from 6 to 12. You see that the amount of high VQ, dead space increases and the amount of shunt decreases. And as they increase the PEEP further to 18, there's not so much change in the shunt, but a little increase in dead space. So this can actually also help you to first find the level of PEEP. Now, not only looking at mechanics, but looking at VQ matching, which is also an important aspect of lung physiology. And interestingly here, they looked at, well, what was the effect of proning in this patient? So the same level of PEEP that the one resulted in the best situation in the supine position was now applied in the prone position. And you see here that proning had a synergistic effect, increased the effects of this optimum PEEP selected during the supine position. And you see a marked reduction in the dead space areas and the shunt. So again, allowing us to improve the mechanical ventilation treatment in these complex to ventilate patients. Another adjuvant therapy that has been used quite a lot during the pandemic is the nitric oxide, and there have been confounding results. We have used it a lot, and we realized that these patients need a higher than normal dose of nitric oxide. And you see here the changes in, for example, in a responding patient from the baseline condition, and after applying 15 ppm of nitric oxide, you see there's a shift of perfusion to the more ventral parts of the lung. And when looking at this or quantifying this, you see here that when applying nitric oxide, this shift of ventilation to the ventral parts of the lung resulted in the decrease in VQ or high VQ areas and a decrease in shunt areas in the lung. Again, showing that in this responding patient, we had a way of understanding what was happening. So this is a clinical example, just another of the nice things that EIT can provide at the bedside. So this is another COVID patient with almost the only thing we have been doing in the last months. So this patient had an pneumothorax, and we could immediately see it in the EIT. And you see here ventilation with almost no ventilation in the right lung and almost no perfusion, because also not only the alveolar collapse, but also the pulmonary capillaries, and there's a pulmonary hypoxic vasoconstriction. So this patient was then drained. So we could monitor the effects of a specific treatment of an important problem that appears at the bedside. And you see here after drainage, of course, the ventilation in the right lung improves, but see what happens with perfusion, still not good enough, and the patient was doing badly. So gas exchange was not improving, so we had to make a decision. And only because we had the opportunity to monitor this patient, and a drainage and with an active drainage was put in place, we dared to recruit this patient afterwards. And actually what we gained with recruitment is a normalization of perfusion and a normalization of gas exchange, again, allowing us to optimize the treatment. So we have all the important components of clinical decision-making. We detect a problem, a serious problem during mechanical ventilation. We monitor the effects of a treatment, and we can monitor the effects of optimizing this treatment afterwards. So all in one. Finally, my last slide is this is a very well-known problem in the COVID patients. We have a massive endothelial component in its pathophysiology, with lots of episodes of pulmonary embolism. And this is just one of these cases. This was borrowed from Brazil, from Marcelo Amato, who kindly gave me this slide. You see here a huge thrombus in the left main pulmonary artery. This, and of course, causing a reduction in perfusion in this lung, and this was nicely catched by the perfusion with the EIT. But you see here, for example, that the patient had a tremendous derangement in gas exchange, and you see what happens here. The perfusion is shifted to the other lung, and here the problem is that you create a condition where you have an excess of perfusion related to ventilation. This behaves as a shunt, and then it allows us to understand sometimes with this difficulty we have been having in correctly interpreting the gas exchange abnormalities in these patients, that, well, we can understand what's happening in this patient and also monitor in case we were able to reduce the size of the thrombus. So to conclude, why is EIT important? Well, it's a magnificent tool to individualize and optimize lung protective ventilator settings over time at the bedside. So it allows us to detect problems and follow the evolution of the patient to the interventions we are undertaking. And it aids in better understanding of complex pathophysiological processes, because it helps us to visualize things that have been classically hitting at the bedside, especially in ARDS patient and gas exchange issues. And this should help in clinical decision making. And with this, I thank you for your attention.
The next speaker does not need too much introduction. So this is the next speaker, Mr. Prone Positioning, Professor Claude Guérin from Lyon.
Thank you very much, Ines, for this kind introduction. Good morning, good afternoon, everyone. I'm very happy to be here. I would like to thank very much Pablo Cardinal Fernandez for the invitation. So the title of the talk is very tough, you know. Prone position after several days of mechanical ventilation is still a useful intervention. So I have no conflict of interest regarding this talk. And actually, my talk may finish here because there is no data, there is no solid data to truly answer the question raised by Pablo. So I tried to do my best to think about that. And first, what is established in the literature by now is that proning should be applied early after ERDS definition and for long sessions, at least 16 hours. And it is considered as a standard of care in selected ERDS patients. And this has been, shown by a recent expert conference of our French National Society and reported by Laurent Papazian and co-workers, and also more recently in this very nice review in intensive care medicine, or in which prone positioning should be applied early in moderate to severe ERDS patients, and it is actually the standard of care. But so the question raised is, could it be that prone position could be used later? And where actually could come a delayed proning from? And I would like just to discuss about that in the coming slides. So the first reason for delaying the prone positioning is that a stabilization period was actually mandated in the literature. For instance, in the trial we did, in the ProSiva trial published 7 years ago, the protocol mandated a period of 12 to 24 hours to allow the ERDS to be confirmed. And at the end of this period, the patients were included if they had a PF ratio less than 150 milliliters of mercury with a PEEP of at least 5 and an FeO2 of at least 60%. So we didn't rush really on prone position, except if the patients was very severely hypoxemic. It required this intervention immediately, as a rescue strategy, I may say. And also there is the series of studies by Jesus Villar in Spain that found and confirmed that in different investigations that the prognosis of ERDS was better defined after a reassessment at 24 hours. For instance, in this study done in critical care medicine 5 years ago, you have 4 different groups of ERDS based on the combination of PF ratio and PEEP, and you see that the discriminative power of this subdivision into 4 groups was significantly associated with hospital mortality, not at the ERDS onset, but 24 hours later. So it is, it is not several days of mechanical ventilation without prone positioning, but there is some hours that was mandated without proning in the literature. The second reason for delaying prone position is that the clinician may judge the hypoxemia not severe enough. And this is what we observed in an international survey we published 2 years ago in intensive care medicine, in which you see that afterwards the clinician followed the recommendation. The odds ratio for a patient to be prone was significantly greater than 1, if they had a severe hypoxemia at the level, at the threshold of 100 of PF ratio. But if you look at higher PF ratio, there is from 139 millimeter of mercury and above, there is a significant risk for being not prone for those patients. And so the severity of, or the non-severity of hypoxemia is a reason for not proning at least immediately. But however, we have this interesting study by Pham and co-workers, which is a sub-study by the lung safe study, showing that mild ARDS patients who did not improve, or even worse during the first week, had a worse prognosis as compared to those patients who either did not worse or even improve. So mild ARDS could benefit from proning, but it is not evidence-based. But based on this observation by Pham et al., we are going to start a new trial in France, testing the prone position versus supine position in those patients with a mild ERDS, in which there is no evidence for a beneficial effect of proning. A third reason through which prone position might be delayed is there is not a good reason. So the clinician wants to offer the patient a proning session, but actually it's not a good reason, really. The first is obesity. And it might be that clinician or caregivers be, a little bit reluctant to prone a patient with a massive obesity due to the heavy workload this situation may result in. Actually, in the literature, we have a few data about the use of prone positioning in obese patients, and we have this nice study coming from the group of Samir Jaber in Montpellier in France, which is a case control clinical study in patients with morbid obesity and ERDS. Some patients were prone and they were controlled by patients who are not prone. And what they found, first, that was surprisingly, the settings were the same between the two groups, with the same 7.2 ml per kilogram predicted body weight in both groups, and same 9 centimeters of water peak in both groups. And you see what is interesting is that in both groups, non-obese and obese, but particularly in obese patients, there is a significant increase in oxygenation resulting from the prone position. So there is a beneficial effect of prone positioning in obese patients, and of the same or even greater magnitude as compared to the non-obese patients. And if you look at the survival probability, this probability was higher was significantly higher in patients with obese and prone as compared with prone but not obese patients. So probably that needs further investigation, more data to confirm the fact that actually obese patients are not a bad reason, but a good reason for being prone without delay. Another not good reason for delaying prone is the abdominal surgical or medical problem. In our APRONET study, that was also the third reason for not proning an ERDS patients after a not severe hypoxemia and hemodynamic problem. But actually, we have also this study coming from France, which is again a retrospective but multi-center study, so the level of evidence is not that high. But in this study, the primary endpoint was the number of patients who had at least one surgical complication after proning, and those patients had a medical or surgical problem. And they look at the patients were either prone or supine, and they look at the rate at which the patients had suffered from at least one surgical complication after the procedure. And you see that there is no significant difference in the rate of this primary endpoint in the prone as compared to the supine position. And again, here, in those patients with abdominal problem, prone position resulted in a dramatic increase of oxygenation. The PF ratio increased by a factor of 2. Another not good reason for not proning or for delaying the prone position in patients is the fact that there is no dorsal lung consolidation. Some clinicians maybe use prone positioning only if there is a dorsal consolidation. But actually, if you look at the recent study by Jean-Michel Constantin and co-workers in France, that was a randomized control trial in which the prone position was mandated in the experimental group if there is evidence for a focal ARDS involving mostly the dorsal consolidation. There is no difference regarding the survival in both groups. But actually, and what is a little bit pity, the per protocol analysis showed up a significant effect of the personalization, and in particular the use of proning in case of dorsal consolidation. But this difference between these two curves was due to the fact that there is a high rate of misclassification, even using CT scan of patients. But the primary endpoint was negative, so the lack of dorsal lung consolidation cannot be seen as a good reason for not proning a patient. A first argument for that may explain delaying proning is really a real contraindication of proning, and probably the 2 or 3 absolute contraindication of proning is an unstable dislocation of spine of long bone, intracranial hypertension, and pulmonary embolism risk, which was high in the COVID-19. But this contraindication may be, temporary, because the unstable dislocation may be stabilized by surgery, and the intracranial hypertension may be monitoring and managed and controlled, and the same is true for the risk of pulmonary embolism. So it could be that over time, this contraindication move from an absolute standpoint to a more relative, and the prone position could be discussed there. A fifth argument for delaying proning is the use of ECMO. So we know that with ECMO we can prone a patient, but ECMO is a step forward in the management of ARDS. The ECMO is used after we fade without intervention, high PEEP, nitric oxide, and prone positioning. But if you look at the EOLIA trial, you see that prone position was probably not used as much as it would have been. It was used in less than 60% of the patient, and probably ECMO was applied earlier without, a trial of prone position. And finally, there is a real, a good reason for delaying prone positioning, that is acquired ERDS, which is something which is not very well defined in the literature. You intubate a patient for a given reason. He doesn't fulfill criteria for ARDS, but those criteria are coming up some days after, in particular if there is a ventilator-associated pneumonia that occurs in an intubated patient in the ICU. And at that time, the patient had criteria of ARDS and also criteria for being prone after some days, of mechanical ventilation. And this is with this hypothesis in mind that we look at a series of consecutive COVID and non-COVID-19 in 5 centers in France. We have 267 ERDS patients. And when we put the threshold at 7 days after the diagnosis of ERDS, including intubation, we observed 27 patients in whom the prone position was used after day 7 from ERDS diagnosis. And the 5 centers, I can tell you, are strong believer of prone position and use prone position regularly, in particular following the PROSIVA criteria. And what we found, there was no difference in mortality rate at day 90, 3 months after inclusion, in those patients who were prone before 7 days as compared to those who were prone after 7 days. But the difference was regarding the distribution of the ERDS stage. And actually, the patients who were prone after 7 days were more frequently in the moderate risk category and less frequently in the severe category as compared to the patients who are prone within the first 7 days. And there was no difference between patients with or without COVID as a reason for the ERDS. So to sum up, if prone position if we assume that proning is efficient by preventing really ventilator-induced lung injury, and I like very much the slide showed up by Fernando about the deleterious effect we may have with prone position as disclosed by the IT, but assuming that if proning is efficient by preventing ventilator-induced lung injury, it should be applied as long as there is a risk of ventilator-induced lung injury, in particular during invasive mechanical ventilation. But, you know, we have some evidence, and this is a recent study we did in Uppsala in PEAK, showing that there is a desynchronization between the effect of prone position on hypoxemia and on VD prevention. For instance, here you have 2 groups of PEEP selection. And in both situations, you see that we have a reduction in the transpulmonary driving pressure, suggesting that we have a reduction in strain. But, you know, this is, in the same time, we have either an improvement, but also a no change in oxygenation. So in conclusion, why was, as a question raised by Pablo, in patients who are not prone earlier, it might be good or bad reasons, and I try to figure out this. And if there is a bad reason, there is a risk to prone the patient too late. I mean, just before this, exactly what we did in the early days. I mean, several decades ago, when we used proning in the early days, where the physician waited for extreme hypoxemia to prone position. Thank you very much for your attention.
Question from Namaste from India. This is a question to Louis Blanc, where the question is whether muscle relaxants should be applied or can be applied for more than 48 hours.
I mean, 48 hours is the threshold limit that is recommended according to evidence-based medicine. Okay. Okay. 48 hours is what is recommended in the literature. However, I mean, if after these 48 hours, I mean, the indication of the neuromuscular persists and there is no way, I mean, to protect the lungs of the patient, then it is reasonable, I mean, to keep the myorelaxants in that patient until we can control, or the clinicians can control, in that case, the situation. I mean, there is one paper comparing neuromusculars only 48 hours and more than 48 hours. I mean, without too much difference, provided this is needed by the patient. So in these COVID patients, I mean, the experience of my group is that sometimes the use of neuromusculars goes beyond after these 48 hours. Therefore, your question is nicely taken, but you need to see or to examine exactly. I mean, to take the decision according to the clinics of the patient.
One quick question to Fernando. It's so fascinating that we can detect regional perfusion and regional ventilation with EIT, and we sell EIT as the method for personalized monitoring. Now, with these two methods, with a PEEP trial that you use and with a saline bolus, would you give an upper limit how many boli you would give per day, or how often you would be willing to do it? How often will you be willing to make a PEEP trial?
Now, there's been a constant effort trying to reduce the amount of saline you need to inject in order to reduce the sodium load of these patients. Now we have learned that it depends on the size of the patient, of the cardiac output, the magnitude of the cardiac output, that you need sometimes to shift a little bit. But even as we did the validation experimentally, this 10 mL of 20% saline, the amount of saline you're giving to the patient is more or less the same as 250 mL of normal saline, a little bit more maybe. So the sodium load is something you need to consider, and especially patients that have problems with sodium elimination or already hypernatremic, you might be limited. I don't have a specific answer on how many times we can do this. We have been using it a lot in the clinic, and sometimes repeatedly in one day, so 4 or 5 times, of course, with close monitoring of the sodium changes, and we haven't seen any major problems. Sometimes the patient is already hypernatremic, and then we try to limit it. If we consider this information is important, do it once and not to challenge the system longer. But I hope that in the future, the system will be improving, and the amount of sodium might be less. But this is just at this point is more a wish than a reality.
Okay, thank you very much for this response. It's nice to hear that. And I have one final question to Claude. I know that you are promoting prone positioning. Is there any future for lateral positioning?
Okay, thank you so much. Thank you for the question. Actually, the evidence is not for. There is no evidence. I mean, we have physiological study showing contrasting results, some benefits in terms of oxygenation, but you may have an improvement in compliance in one lung, a reduction in compliance in the other lung, and there is clearly no, it is not evidence-based, and maybe there is negative results. I'm thinking about an Italian study that used a Trendelenburg position associated with lateral positioning that was not showing any benefit. And there was recently a study showing also some side effects in this situation. So it is, that needs studies, but it is not evidence-based at this time.
Okay, so at the moment, we will stick to prone position. So thank you very, very much to all three of you. Dear Claude, dear Fernando, dear Luis, thanks once again for your wonderful talks. I want to thank the audience for listening. Stay safe and healthy, and look forward to a very short coffee or tea break. Have a nice day. Bye-bye.
Thank you so much, everyone.
Bye, Inés. Thank you.
Bye.
Thank you. Bye.
Thank you very much. Bye-bye.
Bye-bye.